Aparte tenemos otras alternativas, los esquemas de intensidad reducida para evitar mayor morbimortalidad, que se han visto con buenos resultados similares a los esquemas mieloablativos. El trasplante con sangre de cordón umbilical cada vez está teniendo mayor impacto, también con resultados similares comparándolos con trasplantes de adultos de donantes no relacionados. Y el trasplante autólogo más el inhibidor de tirosincinasa también se está retomando. Conclusiones: el paciente de alto riesgo sometido a trasplante en primera remisión sigue siendo una recomendación 1A. El uso de inhibidor de tirosincinasa en la inducción ha mejorado los resultados. Sin embargo, el beneficio del uso de tirosincinasa en mantenimiento y su duración posterior al trasplante aún está en debate. ¿Por qué? Por la tolerancia, a pesar de que son bien tolerados, la toxicidad también, principalmente con neutropenias, y también el favorecer resistencia mediante mutaciones. Es recomendable que se use, sin embargo, cuando se llegue a usar, se debe de tener a la mano un monitoreo. No es adecuado usar inhibidores de tirosincinasa sin llevar un monitoreo de enfermedad mínima residual. Gracias.
Muchas gracias, doctor Valero. Vamos a hacer la presentación en español, pero queremos agradecerle enormemente al doctor Michael Berneris por haber aceptado venir a nuestro país y poder compartir con nosotros esta charla acerca de trasplantes de células progenitoras de sangre de cordón umbilical. El doctor Michael Berneris estudió su carrera en Hanover, New Hampshire, y también realizó su estudio de pediatría en Washington, D.C. Posteriormente, su entrenamiento de hemato-oncología lo realizó en la Universidad de Stanford y actualmente pues trabaja en uno de los centros más importantes de trasplante de células de cordón umbilical a nivel mundial, como es la Universidad de Minnesota. Es por eso que es un honor para nosotros poder escuchar al doctor Michael Berneris toda su experiencia en relación a este tema, pero también el doctor ha trabajado mucho en el área clínica y de laboratorio con células NK y también con células dendríticas. Él labora no solamente en el área clínica, sino también de laboratorio. Por si alguien en especial quisiera preguntarle al doctor, tiene toda el tiempo y la libertad al final de la sesión para poderlo hacer. En esta ocasión pues, nos va a hablar de trasplante de células de cordón umbilical. Dr. Michael Berneris, thank you very much for talk with us.
So I'd like to first say good evening and thank Ines for the really wonderful hospitality and invitation, and it's been a great day so far. And so I thought I would share some of the results of umbilical cord blood transplantation, both from the University of Minnesota as well as other places throughout the country and world. And I thought I would first start with a case where a patient is diagnosed with myeloid leukemia, and the patient receives chemotherapy, and if this is a pediatric patient, actually, and remission is achieved, they don't necessarily go straight to bone marrow transplant, but if they have a sibling that matches, they would go to transplant. However, if they don't have a sibling, by the national protocols that we follow, most of these patients would receive further chemotherapy and maintain a remission. And about half of these people, unfortunately, have a relapse. And then we start looking for unrelated volunteers. And the goal is really to find a compatible unrelated donor. And so what are the choices? So the chances of finding a donor in the US, there is about 9 million donors in the National Marrow Donor Program, healthy individuals who have said they would donate. If you're Caucasian, there's about a 50 to 70% chance of finding a donor. If you're African American, it's about 30 to 50%. And if you're Hispanic, it's actually 20 to 30%. And really, this represents the people who are in the registry. And so depending on your race, the chance of finding a donor varies. And so if there is no donor, what do? Well, you can wait, and then wait some more. Or you could consider alternative donor sources, such as a haploidentical transplant from a parent or a sibling, or cord blood. And really, I'm going to spend most of the talk about cord blood. And so again, the goal here is to try and deliver transplant to as many people as possible. And just the way the genetics work of HLA, you have a chance of about 1 in 3 to have a sibling who matches you. Depending on your race, at least in the US, your chance of finding an unrelated donor is somewhere between 20 and 50%. And so really that leaves this relatively large chunk of people, which is about 15,000 people in the US each year who don't have a donor. And again, they need to consider alternative donor transplants. So just quickly looking at the differences between haploidentical umbilical cord blood in bone marrow or peripheral blood transplant. As far as getting the patient to transplant rapidly, the haploidentical, there's a motivated family member who is willing to do anything. Same thing with cord blood. The cord blood is tested, it's typed, and it's froze, it's ready to go. If you look for an unrelated donor through the National Marrow Donor Program in our country, it takes about 3 to 4 months to get that person, to test them, and then to collect their marrow or peripheral blood stem cells. With haplotransplant, almost all of the protocols require extensive and expensive cell processing. Umbilical cord does not, and some people process bone marrow or peripheral blood. GVH prophylaxis is not typically used, but it is with these other two approaches. GVH does not really occur in this setting, but does occur in cord blood and probably more commonly in peripheral blood. Prompt neutrophil recovery occurs in haplotransplant. In umbilical cord, it's slower, and in bone marrow and peripheral blood, it's faster. However, haplotransplant has really quite poor immune reconstitution. Cord blood is better, and bone marrow may or may not be better. Now, as far as cord blood goes, you know, this was a source that was used almost 20 years ago, and the editorials in all of the very big journals predicted failure. They thought that cord blood would not work. They said that there was data that in cord blood there is some of the maternal cells, and that therefore you were going to get lethal GVHD. And I'll come back to this point later, actually, because this is a very interesting topic. The next concern was there's not enough stem cells, and so therefore you're going to have delayed recovery and you're going to have graft failure. And that's true, actually. That is a major concern. And then lastly, this is fetal blood. This is really immature. This cord blood has never seen infectious organisms. And so therefore, if the patient, the prediction was if the patient didn't die from infection, they would get relapse. Well, most of this has turned out to be incorrect. So the principal obstacle of umbilical cord blood is actually the cell dose, the number of cells. And for most cord blood banks, the median number of cells is about 9 times 10 to the 8th. And this is acceptable for patients that are about 30 kilos. And so really one of the main obstacles to cord blood transplant, and I'll show you why in a moment, is really the number of cells that's available to the patient. And one of the goals at the University of Minnesota has been to really try and bring cord blood to large pediatric patients and to adults. And so this is data that's not projecting all that well, but this is data from Eliane Gluckman's group through the Eurocord, looking at the effect of HLA matching and cell dose. And so if you look at cord blood units that are well matched and have a large cell dose, or that are well matched and have a small cell dose, the outcomes are relatively similar. However, if you have a large cell dose in a poorly matched cord, again, the survival is relatively similar. But if you have a poorly matched cell dose with a poorly matched cord with a low cell dose, the outcomes are really quite poor. So there's an interaction between the number of cells that you give and the matching. Just shown another way, this is data from the New York Blood Center. And now this is shown slightly differently, but this is a 4 of 6 cord blood match, and this is a 5 of 6 cord blood match, and the cell doses are here. So you can see when you give a very high cell dose, the outcomes are about the same. If you give a lower cell dose, there's really no difference. However, when you start getting to this 2.5 times 10 to the 7th per kilo, the differences are starting to become dramatic, and they're further dramatic at even lower cell doses. So cell dose and HLA matching matter in cord blood transplant. And so our algorithm at the University of Minnesota depends on the number of cells that are available to the particular patient. And so our cutoff, our minimum number is 2.5 times 10 to the 7th nucleated cells per kilo for all recipients. And then if it's perfectly matched, we'll go to 3. And then if it's less well matched, we want it to go to 4. And if it's really poorly matched, we want that cell dose to be 5. And you can imagine that this cell dose is not very well achievable in adult patients. And I'll come back to that point in just one moment.